This is the paper that I'm going to present today. It's a paper, as I say, that we published in the ERJ Open Research. Kudos to many co-authors on this. The senior author is my consultant colleague at the Brompton, Professor Anand Devaraj, who's a professor of radiology and director of radiology at the Brompton Hospital and Harefield Hospital. He and I have been working together on much of this, along with a number of other collaborators and contributors from Brainomix and externally, as you can see listed here. So to give you a little background, I know this is a path well trodden for all of you, but one of the challenges we have with idiopathic pulmonary fibrosis, both in clinical practice, in the research domain, and when we consider appropriate timing for lung transplantation, is the disease is somewhat heterogeneous. We always tell our patients that this is unfortunately a progressive fibrotic lung disease with inexorable progression, but the rate of progression is variable and presently impossible to predict. We have emerging circulating biomarkers, but none that have been found to be sufficiently robust for us to use in clinical practice. And so often patients come to us and we say, well, we can't really tell you what's going to happen in the future for your lungs disease, but we'll put you on the right drugs and we'll then follow you up 6 monthly, 12 monthly and beyond. And once we have a sense for the trajectory in time, we will have a better idea for what the outlook may comprise. But even within that, we have these sudden deteriorations, acute exacerbations that are, again, unpredictable. So this is part of the problem. When we think about how we define progression in the context of fibrosing interstitial lung disease, now that may be in the context of IPF or indeed in non-IPF fibrosing ILDs, we use a number of different criteria. And the most accepted criteria are those that involve a combination of lung function decline, patient symptomatology, and progression on CT. And the most previously established criteria for progressive fibrosing ILD or progressive pulmonary fibrosis is the inbuild criteria, some of which is referred to here, although we have slightly adapted it for the purposes of this review article and this sort of joint position piece that we published back in 2020. But you can see that one of the critical components is deterioration in lung function appearance, in CT appearances. And since then, there's also been the publication of the ATS-ERS joint societal guidelines, which is slightly different to these, but includes a 12-month progression timeframe. The problem we have when we consider CT as a tool by which we can evaluate progression is that our radiologists don't always agree. And I don't in any way wish to demean our radiology colleagues. In some senses, many of us chest physicians are indeed frustrated radiologists, but we know that that not only patterning, but also progression can be subject to fairly marked inter-observer variability. And if you see this study that was published back in 2016 by colleagues at the Royal Brompton Hospital, it's not just the pattern that differs, it is also the extent of disease that can be very variable when radiologists evaluate it. And interestingly, as our radiologists become more experienced, they agree less. So read into that what you will, but suffice to say, we have a challenge here regarding the ability for our radiologists to agree on various measures that we use or consider sacrosanct when we look at disease progression. And we have defined a number of imaging biomarkers that we have defined and now validated in different forms. We use convolutional neural network based deep learning methodology, and we can automatically segment the lungs, quantify the volume of the lungs, and then using different measures and methods, we have defined a new biomarker, which is called the reticular vascular score. And the reticular vascular score is a score which encompasses all of the fibrosis throughout the lungs, taking into account not just the fibrotic structures, but also the vascular structures. And that combination of the fibrotic abnormality and the vascular structures has combined to create what we think is a very powerful prognostic biomarker. So the total amount of disease or fibrosis in the scan is the reticulovascular score, but we have then defined a novel biomarker called the weighted reticulovascular score, the WRVS. And that takes into account the peripheral disease. So it is weighted towards the periphery of the lung, and that in particular has been shown to be highly prognostic. And I'll show you some data now that leads into the study that we published in the ERJ Open Research. We published this paper in the Blue Journal again in 2024. I won't go into too much detail in this study, but this was a cohort of patients from an AstraZeneca clinical trial, a completed data set of tralokinumab. These were patients in whom this was a negative trial, and all patients progressed over the course of the study, essentially in a placebo format. So, but to the same extent by which we might expect a patient on a placebo in an IPF clinical trial. So these are antifibrotic naive patients, essentially. And what we found is that when you subdivide this score, the weighted reticulovascular score, into thresholds, you're able to predict with fairly good accuracy patients whose lung function will decline over the next 52 weeks. So on the left-hand side, you can see that patients who have a WRVS of greater than 15% have a hazard ratio of over 5.5 for lung function decline over the next 52 weeks or 12 months. Whereas those with a WRVS of less than 10% in the blue line on the right-hand side have almost no chance of losing their lung function over the following 52 weeks. And so this has started to help us streamline patients who are at risk of clinical progression, IPF, and we have found subsequently non-IPF ILD for future lung function decline. So I'll start now on the paper itself that we are discussing. And the aims of our study was, off the back of the Blue Journal paper that I just showed, we wished to evaluate the performance of WRVS in predicting not just short-term lung function decline, but rather lung function decline as well as long-term outcomes, including mortality. And we looked at the relationship between baseline WRVS and future FVC decline and mortality, and crucially, the association between serial change in lung function and mortality. And so there's been a number of papers that have shown that serial change is much harder for quantitative CT algorithms to define. And so this was an important part of what we wished to do. We took patients from the OSIC consortium, that's the Open Source Imaging Consortium. This is a consecutive group of patients with IPF, and we divided them into test and validation cohorts. We selected patients who had a baseline CT scan and a 12-month follow-up CT scan, and they needed to have, at the same time points, lung function tests at baseline and at follow-up, and they needed to have long-term mortality outcomes. And in so doing, we would be able to evaluate progression on CT against progression in lung function and fibrosis extent visually, and evaluate that against long-term survival. This is the nature of the cohort. You can see a fairly typical IPF cohort, patients in their late 60s, early 70s, mean lung function decline, mean lung function FVC around 82%, and a large number of ex-smokers, so fairly typical. This is the first data slide. And what we showed in sort of confirming what we've seen previously is that patients who have a WRVS of more than 15% have a significantly higher risk of transplant-free survival versus those who have a WRVS of lower. So the WRVS score of 15% is a clear line in the sand for predicting patients at risk of mortality. And the RVS of 10% was slightly inferior to that, but also prognostic, which again speaks to the fact that the peripherality of disease in fibrotic ILDs, and we know peripheral disease is very important, is the most prognostic feature when we look at these patients. This is showing you once again the same data, but showing you on the left-hand side the test and in the right-hand side the validation cohort. And you see once again very, very similar data. A WRVS of 15% or above versus WRVS of 15% or below in the blue and the grey lines. And on the bottom, you can see what this biomarker looks like. So on the left-hand side, you have the native CT scan. On the right-hand side, you have the red biomarker, which is the reticular vascular structures, which are automatically segmented and calculated. And later on, I can talk to you a little bit more about how this e-lung technology integrates into your clinical workflow. But suffice to say, it takes between 60 to 90 seconds for the scans to be processed and then the biomarkers to be generated, allowing you to make decisions for your patients almost in real time. Importantly, what we also found is that a change in the WRVS of 3% is strongly associated with poor outcomes. So patients whose WRVS rises by 3% have a hazard ratio for mortality of over 6. And whereas we have subsequently found that you can actually bring down that WRVS to probably a change of around 2% is still significant in being able to define progression. And in fact, the minimum clinically important difference is probably even less than that. We found that this threshold of 3% was the most sensitive for differentiating the likelihood of progression. We then looked at comparing 3 individual ways of evaluating a patient, comparing baseline and 12-month data. So we asked 2 expert thoracic radiologists to define progression, yes or no, at 12 months. We asked them, we then looked at lung function decline, and we considered a drop of 10% to be significant for lung function decline. And we used the WRVS of 3% as our threshold. And we compared each one of these elements and assessed and evaluated a risk of mortality thereafter. And you can see, first of all, that any one of these 3 measures of evaluating serial data is strong. But you can see that radiologist progression is slightly inferior to FVC decline of 10%, which again is slightly inferior to a rise in the WRVS imaging biomarker. So that shows us that we really have an opportunity to improve upon our current existing tools when we think about how we prognosticate for our patients. And that might have relevance to the date of and timing of transplant listing, as well as integration into clinical trials, and perhaps in sometime soon, escalation of therapy to consider combination therapies. And that I think is all moving into the future. The next, now I'm going to show you some new data. These are data that I presented, some of which at the American Thoracic Society a couple of months ago now. The next question we wish to answer was, how important is a UIP pattern on CT? So you will all know that a UIP pattern has historically been long considered the archetypal feature on a CT scan, and indeed that feature on a CT scan is simply a correlate for many of the older biopsy studies where UIP versus NSIP histologically was compared and then evaluated for outcomes, and then thereafter we defined what UIP looked like on a CT scan, and we know the cardinal features are subpleural reticulation, traction bronchiectasis, lower lobe predominance, etc., lack of ground glass. And so we know that UIP is important. We also know, as I've shown you earlier, that UIP is subject to intra-observer variability, and so we have an issue there. Over the past few years, a number of AI-based algorithms, including the Sophia algorithm, including the Embio IQ UIP, have sought to improve upon the visual ability to identify UIP. And we've seen time and time again that algorithms outperform visual assessment of UIP when you anchor against long-term outcomes. However, there is a paradigm change here, and over the past 12 months, 4 important papers have been published that have shown that more important than UIP may be extensive fibrosis. And using either deep learning models, for example, the DTA technology from National Jewish, using acute quantitative lung fibrosis, the UCLA technology. There's been a few studies that have shown that extensive disease outperforms UIP. So we look to evaluate this in a study of our own, and this is data I'll show you now. So we took 300 odd consecutive patients, this time with non-IPF fibrotic interstitial lung disease. These patients had a mean FVC of 83%. They were mean age of 65, predominantly men, but really almost a 50-50 split. And the scans were scored for UIP status by Anand Devraj, Professor Devraj, and we combined definite or probable UIP as UIP and indeterminate and alternative diagnosis as non-UIP. We also asked 2 thoracic radiologists to score the extent of disease on the CT scan visually, and across all these scans, the mean extent was around 20%. And we then sought to evaluate the relationship between UIP status, extensive fibrosis visually, WRVS, so these 3 metrics, and long-term outcomes. And what we see here is that we'll focus on the top first, mortality. The C index is a measure of how well a variable predicts an outcome. So 1 is perfect. And the closer to 1 you have, the more perfect your ability to predict an outcome. So you can see that when you look at the WRVS, when quantified as a continuous variable, the C index is 0.75, which just outperforms extent of fibrosis as evaluated visually by a radiologist, but really quite significantly outperforms UIP. So that's really replicating what we've seen previously in IPF. And then if you look at the ability to predict, or the association with 10% FVC decline, once again, WRVS significantly outperforms visual fibrosis extent, which outperforms UIP. And you can see that only WRVS and the extent of disease visually remain significant, whereas UIP is not able to, the presence of a UIP pattern on CT has no association with future lung function decline. So really changing that paradigm and really suggests to me that what we may have in this WRVS biomarker is almost a score of UIP, a UIP extent score, which intuitively you would imagine is likely to be much more sensitive than a binary biomarker of UIP versus non-UIP. And that's really where I think the biomarker is telling us. It's telling us about the extent of UIP, the extent of fibrosis, and the extent of vascular abnormality. When you combine those 3 measures, I think you have a very powerful prognostic marker. This is data which compares once again WRVS again high in red versus low or middle at baseline in green. And this is we split the biomarker into tertiles. And once you have a high WRVS, and here it was about 15% again, your hazard ratio is 4.5 in non-IPF ILD. But on the right-hand side, you can see that patients who have UIP in the red line and without UIP in the blue line, there is separation, but it's fairly it's not as stark as you see when you use the imaging biomarker as a differentiator and a prognostic tool. And this is, I think, quite illustrative data, because here what you have is in the red lines at the bottom, you have a high WRVS with UIP in the pink and without UIP in the red. So regardless of whether you have UIP or not, a raised WRVS is associated with poor outcomes and mortality, whereas in the blue, a low WRVS with or without UIP is associated with better outcomes. So once again, adding more weight to this concept that we can go beyond UIP and we have a slightly more nuanced biomarker available to us. This is data from the INBUILD study. You'll remember that the INBUILD study was the registrational study of nintedanib in progressive fibrotic ILD, PF-ILD, what we now call progressive pulmonary fibrosis. And importantly, lung function was able to show us a treatment effect. And most recently, we were delighted to see the same modality able to define a treatment effect in the Fibronis study, showing that nerandomilast is effective in PPF and in IPF. And we had concerns about the fact that lung function may not be sensitive to a treatment effect as we are adding on to standard of care. But thankfully, that's not been shown to be the case. However, lung function is sensitive to a treatment effect, but we have data that visual evaluation of disease progression on CT is not sensitive to a treatment effect. So in the same INBUILD study that I've shown you in the slide prior, where we saw placebo and nintedanib separating out nicely using FVC, 3 expert radiologists, and these were Simon Walsh, Nicholas Vetsalati, and Anand Devraj, were given the CT scans from the INBUILD imaging sub-study. So in INBUILD, there were 600 odd patients who were recruited to the nintedanib study. Around half of them were recruited to an imaging sub-study where they had baseline and 52-week CT, and in fact 6-month and 52-week CT scans. And the readers were blinded to time, point, and treatment. And the summary of this study, which was presented at the ATS a few years ago, is that using visual inspection and visual evaluation, it is not possible for radiologists to identify a treatment effect, even in the context of a highly controlled clinical trial. There was perhaps a signal to a reduction in ground glass progression in the nintedanib treated group, but really no clear signal for a treatment effect here. And so whereas the lung function is still useful for us, we don't think we can use CT in the context of a clinical trial. So we sought to evaluate this using 2 AI-based imaging evaluations. And so we used the Brainomix e-lung technology that I've already mentioned to you extensively. And we also used the QLF, QILD technology and platform, which comes out of UCLA by Jonathan Golden and Grace Kim. And just to orientate you here, these are a patient at baseline, top panel, 12-month follow-up, bottom panel in the INBUILD study. Native scans on the left. In the middle, this is the output from the UCLA QILD, QLF, so quantitative interstitial lung disease and quantitative lung fibrosis. And on the right-hand side, the Brainomix output. And the yellow is ground glass, and the red is the fibrotic abnormalities and fibrosis. And again, to orientate you, QILD is quantitative ILD, which takes into account reticulation, ground glass pacification, honeycombing. It's essentially the totality of the ILD on the scan. And the e-lung total disease extent is exactly the same for the Brainomix e-lung. It incorporates the reticular vascular structures and the ground glass pacification. So it's the totality of the ILD. This is the first data slide. We presented this again at the ATS this year. And what you can see is that using the QILD score, quantitative ILD, there is a treatment effect comparing nintedanib and placebo, both at week 24 and at week 52. I think what's really nice to see here is that in half the number of patients as was required in INBUILD and in half the time, you're seeing a treatment effect. And once again, using the Brainomix e-lung total disease extent, you see a strong evaluation here of the treatment effect of nintedanib at week 24 and at week 52. And just so you get a sense for how these data were generated, the company who make nintedanib, Boehringer, provided the scans to Brainomix. The team sent back a biomarker output blinded to treatment indication, and then all the statistical analysis was performed in-house by the company, who then also did the same with the QLF data. So really both algorithms were totally blind to outcomes. This is data which shows how prognostic these biomarkers are from the baseline CT scan in the patients who were randomized to the placebo arm. So the way that you interpret this data is that for every log increase of each one of these biomarkers by 1%, this is the amount of FVC mil that you might expect a patient to lose over 52 weeks. So for 1% increase, a log 1% increase in the QILD, a patient might lose 19.8 mils of their FVC over the next year. And the most prognostic, based on these data, is that the E-lung WRVS, for every log 1% increase in the WRVS, a patient would lose 28.6 mils of their FVC a year. So now we're starting to not just quantify the risk of mortality, we're starting to become even more granular and quantify the amount of FVC a patient might lose over the course of a year based on a rise in the individual biomarkers. Here we divided the data into the medians of the cohorts. So the median QLF, for example, in the orange was 14.4%. The median WRVS was 14.9%. And you can see that those patients who had a baseline QLF of less than 14.4% lost 139 mils over the year, whereas those more lost 234 mils. And the same again for the WRVS. Those with a low WRVS lost 156 mils, and those with a high WRVS lost 223 mils. And so in a placebo treated antifibrotic naive group of patients, you can once again see how you might risk stratify patients with non-IPF ILD for lung function decline over the next year. Again, looking at time to absolute decline in lung function or death. So these are sort of a combined metric by baseline scores using QLF, hazard ratio of 1.7, using WRVS, hazard ratio of 2.1. And these are very comparable, I would say. I think this gives us the confidence that regardless of which of these imaging biomarkers and quantitative CT tools you use, we are able to predict patients at risk of lung function decline over the next year. And once again, this is time to death. So time to death over the entirety of the trial. So going out to 3 years now, your baseline QLF and baseline WRVS both have a hazard ratio of 2.9 for risk of death. So important when you start to think about your patients in the context of advanced therapies and transplantation timing. I'll pivot a little bit into where we are moving this technology forward. So we think that there is an opportunity to use this technology for the screening of patients who have undiagnosed interstitial lung disease, so what we call interstitial lung abnormalities, ILAs. And this is just an example case of a patient who had a low-dose lung cancer screening CT with us. We evaluated their WRVS of being 6.9%, and then just under 2 years later, their WRVS has risen to 10.3%. So this is a patient who has clearly progressed and who, on that basis, might be recharacterized as having an ILD and who might benefit from an antifibrotic drug. I'll tell you a little bit more about the company now, and the last couple of slides our future plans and hopefully our opportunities to collaborate. So as you might have guessed from the name, Brainomix didn't start as a lung company, and in fact span out from the University of Oxford in the UK to commercialize the first ever imaging biomarker for stroke. And over the course of the past 15 years has really matured into a world-leading company, having scanned now over 2 million patients in, I think, nearly 400 sites now and hospitals across the world with a number of clearances. And really, it has been this vehicle which has allowed us to develop our opportunity to improve the care of patients with lung disease, ILD, and eventually lung transplantation with our E-lung offering. We have now 2 FDA clearances, and this technology is available for clinical use in the United States. It's not actually available for clinical use in the UK, where I'm currently sitting in my hospital office at the Royal Brompton Hospital. We have it where we're able to evaluate it, but we're not able to use it clinically, which is challenging for me, as I would love to get my teeth into using it for real clinical use. But we will be there soon. And our vision is to really transform the way that patients with advanced lung disease, specifically interstitial lung disease, are managed across the US. We want to create these e-lung powered networks, and we've shown how we can do that in stroke. So, for example, there are national tenders in a number of countries where Brainomix e-stroke has the entire country networked, so that any patient who has a stroke in any hospital there automatically has their CT brains processed through the Brainomix technology. And we've seen that that improves outcomes. Patients are more likely to have thrombectomy, mechanical procedures, better outcomes functionally, and reduced mortality. And we envisage the same opportunities in interstitial lung disease and specifically progressive pulmonary fibrosis. So I think, just to summarize, I hope I've shown you that over the course of the last few years, we've been able to demonstrate that this imaging biomarker, the WRVS, is prognostic, and it outperforms a number of our currently used measures. We've shown that we're able to identify disease progression where maybe it's not so obvious on visual inspection or assessment. I think we could consider how to use these data when we think about prognosticating for our patients and considering timing of lung transplantation. So with that, I'd like to thank you again, and to my chairs, I'm very happy to take questions.